All right, guys. Okay, so, all right, so I think I pretty much met everybody at this point, but for those who don't know me, I think it's mute. Oh, I'm still muted? I thought I hit unmute. All right, we're good. All right. So I think I know pretty much everybody here, but for those who maybe haven't met yet, my name is Matt. I'm one of the first years. Today we'll talk a little bit about hypo and hypernatremia and the ICU patient, something we deal with all the time. So objectives, pretty simple: to review sodium and water balance, and really to hammer home that when we're talking about hypo and hypernatremia, we're really talking about disorders of water balance more so than necessarily sodium balance. The impact on ICU care, we'll talk a little bit about that, and then the workup and management of water balance disorders. Disclosures, unfortunately, none. So sodium water balance disorders are common, and pathophysiology is frequently misunderstood, or at least oversimplified. Plasma sodium concentration is regulated by changes in water intake and excretion. So thirst and excretion mechanisms, not necessarily changes in sodium intake and excretion. Those are much less common and only happen in very severe cases, really. So in general, the schema you should have in your head is that hyponatremia is intake of water that cannot be excreted. So either alteration in intake or an alteration in excretion. And then hypernatremia is loss of water that has not been replaced. So we'll go through some of the kind of dry material and definitions to understand first, real quick here. So total body water is the percentage of lean body weight made up of water. It generally decreases with increasing age, as well as decreases with increasing fat composition. Two components, intracellular and extracellular fluid. We won't go necessarily into the weeds with that. Intracellular fluid does comprise about 2/3 of the total body water in normal adults. So then the other about third is extracellular fluid, regulated by alterations in sodium excretion. They're mediated by the RAS system, as well as natriuretic peptides, which lead to sodium excretion. They respond to changes in pressure, not changes in volume, which is an important thing to note in terms of some pathophysiology of certain disorders. And then in general, effective arterial volume and pressure change in parallel. The certain disease processes where this isn't true, CHF and cirrhosis, where pressure and perfusion is decreased despite an increased extracellular fluid volume. That's due to either decreased cardiac output in CHF or vasodilation in cirrhosis. Some important definitions and differentiations. Plasma osmolality, so that's the ratio of plasma solutes and plasma water. So that's mainly dependent on sodium, and then you also have some contributions from other ions, mainly glucose and BUN. So you can see the equation here. Unless your glucose or your BUN is very high, they're going to have very minimal to no effect on your plasma osmolality. Plasma tonicity, which is kind of the more important thing, or you'll hear it referred to as effective osmolality, is what's really sensed by the osmoreceptors, and it determines the distribution of water throughout the body. So tonicity, basically the equation is you take BUN out. And the reason is that BUN can easily diffuse across the plasma membrane, so it really has no effect on tonicity. And so you can see it's concentration of solutes that do not easily cross the cell membrane. And that's important to note because renal failure patients can have hyponatremia and they can have a high osmolality with the BUN being high, but they're actually hypotonic often. So they have a low tonicity. How is tonicity regulated? So as we said, there's osmoreceptors in the hypothalamus. And if there's low tonicity that increases, or sorry, high tonicity that increases thirst and ADH excretion. And then ADH is the primary physiologic determinant of free water excretion. So increase in ADH reacts to the V2 receptor, which leads to movement and fusion of aquaporin channels in the cell membrane, which then leads to free water reabsorption. Suppression of ADH is the primary protective mechanism against water retention and hyponatremia, whereas thirst and activation of ADH is a primary protective mechanism for hypernatremia and water loss. This is basically a pictogram of what we talked about, the ADH or vasopressin response. So why do we care? For a lot of reasons, some of which, especially particular to the ICU, are important. So hypo and hypernatremia are very common in the ICU. Studies indicate hyponatremia is present to some degree in 30 to 40% of ICU admissions. Not necessarily as the primary reason that they're in the ICU, but as a secondary reason as well. Hypernatremia, not necessarily as common, but you can see 2 to 6% on admission to the ICU have hypernatremia, and almost more importantly, 6 to 26, so a significantly higher percentage, will develop it at some point during their ICU stay. And a lot of times that's really iatrogenic. You know, we necessarily aren't paying close enough attention and managing their water balance. Mortality, also there's mortality differences in patients with sodium disturbances. Patients who have a free water imbalance, either hypo or hypernatremia, can have double or even more increase in mortality in the ICU, depending on what studies you look at. And then hyponatremia and CHF and cirrhosis has been well documented that those patients have a higher mortality as well. So very common and also increases mortality for our patients. So let's go through a little case here. You guys are still eating, so I can read it. So we have an 85-year-old female, comes to the ER with dyspnea. She's febrile for several days, has had cough productive of yellow sputum, as well as some general fatigue and drowsiness. On exam, she's well developed, thin female and moderate respiratory distress. Blood pressure is okay with no change withstanding. Pulse, respirations are a little bit elevated and labored. She is febrile. She weighs 60 kilograms. Heat exam is unremarkable, and the cardiopulmonary exam is just demonstrates decreased breath sounds at the right lung base. Remainder exam is normal. She's slightly drowsy and a little lethargic, but she's awake and she's oriented. And this is what her X-ray looks like. So, and her labs. So obviously you see she's got right lower lobe infiltrate, and then in her labs, really the only remarkable thing is sodium of 120. Everything else looks okay. So it looks like, sorry, she has right lower lobe pneumonia with hyponatremia. So what's the next step in working up and managing her hyponatremia? What should we do with her? What's that? Repeat the lights. Okay. What's that? Okay. So for the pneumonia, yeah, we want to figure out the cause, so get respiratory cultures, all of that. But for the hyponatremia, okay, assess volume status. Is she euvolemic, hypovolemic, hypervolemic? What else? Serum osmolality, okay. Urine electrolytes, mainly urine sodium. And urine, okay, great. All right, so let's talk a little bit about hyponatremia, and then we'll come back to that case. So we already, as we all know, hyponatremia is defined by sodium less than 135, and kind of this inability to excrete water or over intake of water. So there's different ways to categorize it, so mild, moderate, and severe, based on the level, as well as dividing it into acute and chronic. And it's always important to remember what acute and chronic means. So acute means within 48 hours, and chronic is anything greater than 48 hours. So even if they have, you know, a pneumonia that's we think of as an acute process, they may have a chronic hyponatremia if it's been going on for 3-4 days. So, and then evaluation, it really should be stepwise, and you focus on just answering a few key questions. So what's the first thing when you have a patient with hyponatremia that you want to look at and rule out? The first step. Okay, clinically, yes. So how about in the differential diagnosis and figuring out what is the cause of their hyponatremia? What's that? Okay. Medications is important. Glucose, yeah. Glucose or other causes of basically either pseudo hyponatremia or hypertonic hyponatremia, right? So this we've seen throughout the years. You basically do your first evaluation to make sure the glucose is fine and they're not hypertonic, and then you move down to volume status. I actually am going to go through this one instead because it's a little more, it's a little easier to go through, and it makes a little more sense stepwise in your head than necessarily the first one. So, like you said, the first step is determine if they have either pseudo hyponatremia, hypertonic, or isotonic hyponatremia, rather than true hypotonic hyponatremia. And then you start with checking a plasma osmolality for that. Hyperosmolar hyponatremia causes include hyperglycemia, mannitol infusions, IVIG, as well as recent prostate and uterine surgery. And then we all know, obviously, the correction for glucose, 1.6 for every 100 over 100. Isoosmolar hyponatremia, or we often use pseudo hyponatremia. Causes can include paraproteinemia, lipemia, especially with triglycerides, and obstructive jaundice. That's not necessarily because of the bilirubin, but actually because of an elevated lipoprotein X that is present when you have obstructive jaundice. And in general, it's thought of as a lab artifact. And interestingly, if you have point of care values, those won't be generally affected the same way that lab values would. So you may see a very low sodium on a lab draw, but if you had a point of care sodium, it actually might be normal. So specific to hypoosmolar hyponatremia, which is what we're more worried about, the first next step in the first algorithm would have been to check their volume status. But in this schema, it's more kind of lab-based at the beginning. So you check their urine osmolality. So you want to know, is their urine dilute or not? So if their urine is dilute, then you think of disorders like primary polydipsia, low solute intake, and beeropotomania. So if their sodium, or if their urine is not dilute, then you kind of continue down the pathway. And the next step is to check a urine sodium. If the urine sodium is low, basically that means there's a low effective arterial blood volume being sensed by the kidneys. So then is where your volume status comes into play. So if their volume status is high, then you consider the OSI, the heart failure, cirrhosis, and nephrosis. If they seem to be hypovolemic, then you think of diarrhea, vomiting, third spacing, or this kind of post-diuretic state. So if they were on diuretics, but the diuretics were stopped, then you can have the low sodium as well. If the urine sodium is high, then the next step is simply medications. So are they on diuretics? If they are, then obviously you should consider that as a reason and consider stopping them. But you also don't want to kind of end there. You still have to consider other causes as well. If they're not on diuretics, then you again do your volume status. If they're hypovolemic, then you consider vomiting, adrenal insufficiency, specifically primary, and the salt wasting syndromes. If they seem to be euvolemic, then you think of SIADH, as well as secondary adrenal insufficiency and hypothyroidism. All right. So back to our case, we get the urine studies. The sodium is 60 with an osmolality of 500. So going down our algorithm here, so osmolality is greater than 100. So then we'll come down here. The sodium is 60, so it would be greater than 30. I don't know if it specifically mentioned it, but he wasn't on any diuretics that it said. So we'll go on the side of no. For his volume status, he wasn't having any vomiting that it said. He has really no cause for the renal or cerebral salt wasting or specific reason for adrenal insufficiency. So more likely we're leaning towards the euvolemic with SIADH from his pneumonia. Most likely cause. And then what should we do in terms of management now? Ideas? And how would we characterize his hyponatremia? Is it acute, chronic? Is it mild, moderate, severe? Do you want me to go back to? Nope. So this is the story, but we'll go back here. So sodium was 120. We'll say we don't have any prior lab values, and this is kind of the story. Okay. Yep. So we characterize it as chronic, not acute. And important, unless you know for sure that it's acute, you're going to treat it like it's chronic, right? And then moderate to severe, right? So 120 is kind of right on the borderline between moderate and severe. So in terms of management, we'll talk about that next. Some important considerations when you're thinking about management include the severity of symptoms. So mild and moderate are kind of relatively non-specific. So just about anything you can think of could be included as a symptom, but headache, fatigue, lethargy, nausea, vomiting, some gait disturbances, muscle cramps. So usually these symptoms are seen more often in chronic hyponatremia that's severe, as opposed to the severe symptoms, which include seizure, obtundation, coma, and respiratory arrest. Usually these are more often seen in either acute hyponatremia or very, very severe and low sodium levels in chronic hyponatremia. Indications for hospitalization. So if they're either severe, so less than 120, if they're acute, or if they're symptomatic, really you should be hospitalizing. This is hyponatremia management. So the treatment approach depends on duration, like we said, as well as the severity of symptoms and the severity of the hyponatremia. So the more acute the hyponatremia, the more the greater the risk for complications of the hyponatremia itself, specifically cerebral edema, seizures, and herniation. And so the more aggressive you're going to be with therapy and correction. In chronic hyponatremia, especially if their baseline sodium level is very low, then there's greater risk for complications from overaggressive therapy and overcorrection. And so then you have to be more cautious and monitor more closely. Specific goals with therapy. So really the two main things you're trying to accomplish is one, increasing the sodium by enough to prevent complications of untreated hyponatremia, specifically cerebral edema and herniation. And then two, prevent overcorrection and iatrogenic brain injury from ODS. A general rule of thumb you can remember is this rule of sixes. So you increase by 6 in 6 hours, then stop, and then increase by 6 each days after. That's more specific to chronic, but in general, it's a good rule of thumb because increasing by 6 generally is enough to prevent herniation, even in patients with really severe hyponatremia, and often even in acute hyponatremia as well. So we'll talk about acute first. So causes, we often hear about the ecstasy use as well as Haldol, thiazides very rarely when they're first started on them, desmopressin, oxytocin, and IV cyclophosphamide, which I was unaware of. So if you know that it's acute, so you have specific measured values within the last 48 hours, or if the story is just too good, right? Like a very healthy young individual, no medical problems, used ecstasy last night and comes in the morning completely obtunded with a sodium of 110, then that's really too good to think that it's not acute. So here, really, it's going to be boluses of hypertonic saline with hourly monitoring. And your goal is really to move them back to normal as quickly as you can, or back to what their previous sodium was. So if you know their sodium was 130 a day ago, and now they're 110, there's no real reason to avoid going right to 130. But if there's any doubt, obviously, if they have some risks, but there's no measured value and you're not sure, increases in 4 to 6 are generally enough to reverse cerebral edema and to avoid herniation. So the cautious approach is generally better. Chronic hyponatremia management is a little bit different. So here's where the rule of sixes basically comes into play. So you want small incremental daily increases in serum sodium of 4 to 6. And basically that'll, like I said, decrease the risk for cerebral edema and herniation, no matter how low the original serum sodium concentration is. Larger increases really offer no therapeutic advantage, and they only increase the risk for neurologic complications. Monitoring will be a little bit variable depending on their symptoms and the specific level, but usually somewhere between 2 and 4 is enough for chronic patients, especially who are severe. And then you're going to want to monitor urine output closely, both for the treatment as well as for overcorrection, because if they overcorrect, the urine output can become important. So medications you can use desmopressin 2 to 4 micrograms every 8 hours, along with hypertonic saline. So if they have severe symptoms, so this would be coma, seizures, obtundation, or respiratory arrest, then you're really going to want to use high boluses, usually 100 ml boluses, and recheck after each bolus to make sure that they've gone up 4 to 6. And then you stop and you hold and monitor at that level until the next day, and then you again kind of resume going up. If they have, so you can either do bolus or you can do the 1 ml per kg per hour infusion. And then if they have mild to moderate symptoms, usually you're going to start at a lower infusion rate, more 0.2 to 0.4, and then you adjust over time to achieve your goal. And when they have chronic severe hyponatremia, generally you want to continue these treatments until they're greater than 128, and then you can kind of step down your therapy a little more. So quick case. Probably want to break from my voice. Does anybody want to read it?
I have a quick question before we get to that.
Yeah.
In terms of with the 3%, did you come across anything in terms of central line versus peripheral line?
Yeah, so generally, I didn't include that, but there's data showing that it can be safely administered through peripheral lines. Yep. Yeah, there weren't any specific adverse events in studies directly comparing them. So, any takers?
I'll read it for you.
Okay.
60-year-old male presented to the clinic to review labs with a history of hypertension, diabetes, and blood cancer, for which is undergoing treatment. He voices no complaints at this time. He underwent a colonoscopy 2 years ago and didn't identify any lesions or polyps. He's up to date with his eye exams. The only meds are metformin and lisinopril, and his physical exam does not reveal any JVD or edema or any other pressure sitting is 124/82. When he stands, his blood pressure is 120/80. His A1C is 6.4. And CBC is fine. Labs show LDL of 58. CMP is normal. Except for sodium of 123, and his osmolality is 2. He says his appetite said great and denies any weight loss. He also denies any vomiting or diarrhea, which is calling the fast solution for hyponatremia at this time.
All right, great. So you want to start this guy on Lasix. Does he need to go to the hospital and get hypertonic saline? Do you want to just give him a normal saline bolus and call it a day? Do you want to start him on fluid restriction and possibly demeclocycline? Or do you, for some reason, want to give him D5W? Avoid overcorrection. What do you think? Let's say his urine osmolality is greater than 100 and his urine sodium is greater than 30. What's that? D? Okay, great. Yep. So D. The reasons being, so he has moderate hyponatremia, right? 120 to 130. It's hypotonic with his osmolality. It's probably chronic, and also he's asymptomatic, right? So all these are important. If he's having symptoms of hyponatremia, you might want to have him go to the hospital for more treatment, but he's completely asymptomatic. So at this point, his likely cause is SIADH from his lung cancer, for which you can just start fluid restriction and consider demeclocycline. So other treatments other than hypertonic saline, fluid restriction, so especially for hyponatremia in either edematous states like heart failure and cirrhosis, or in SIADH or advanced renal failure, you consider using fluid restriction. What that means is less than 800 cc's per day, or less than about 50 to 60% of their daily fluid requirement. So pretty low amounts. One thing I came across that's that you can use to help kind of guide you and to know if this is going to be effective is the urine to serum cation ratio. So basically, if their urine sodium and potassium to serum sodium value is very low, which means they have more dilute urine or at least no natriuresis, it's more likely to work in terms of fluid restriction. If the ratio is very high, fluid restriction is probably not going to have a huge effect. Other treatments, loop diuretics, mainly in patients who are hypervolemic, and they also are more useful in patients with a higher urine cation ratio. And that leads to more dilute water in the urine and increased water loss by basically causing a relative ADH resistance. Salt tabs, so mainly in SIADH as well as some other disorders with a sodium greater than 120 and either absent or mild symptoms. And usually using that along with fluid restriction. And then vasopressin receptor antagonists like tolvaptan can be used. They cause a selective water diuresis leading to increased sodium. They do cause an increase in thirst. So the patient's generally going to have a response to drink more water, which limit their effectiveness, and they also can be very expensive. So depending on where you are, and insurance up to like $300+ a pill. It's very expensive. Other considerations, things to take into account when you're treating, especially in the ICU, you want to think about unaccounted free water intake from tube feeds as well as IV meds. The one we often think about is the heparin drip being in dextrose water. So that can be a really high amount of fluid. So you have to make sure that's accounted for when you're thinking about your fluid restriction. As well as the dosing of desmopressin and saline in extreme obesity. We already talked about how the total body water as fat goes up is a lower percentage. So if you're dosing based on weight with really high BMIs, you're probably going to be overdosing patients, especially with the saline. So something to keep in mind, especially with continuous infusions. And then also timing of blood draws versus timing of administrations of saline is important. Important thing to know. So prevention of ODS, something we always worry about. So the risk is greatest in those with severe hypernatremia, especially in those with a sodium less than 105, and chronic hypernatremia. So other risk factors to think about include alcoholism, liver disease, hypokalemia, and malnutrition. And then, like we've already said, if time is unknown, play it safe and treat as chronic. And then prevention, obviously, sodium should be raised by no more than 6 to 8 in any 24-hour time period. So there's 3 kind of ways to try to prevent or treat overcorrection. So if you have a patient with a very reversible cause of hyponatremia, as well as an increased risk for ODS, maybe they have liver disease and alcoholism, then you can consider a proactive strategy. So what that would mean is basically to give them desmopressin right at the outset of treatment, inducing iatrogenic SIADH, and then using hypertonic saline to have a controlled correction. So basically having a better control over how quickly the sodium levels will rise. The second way is what we more often use, which is looking at the sodium trajectory. So if it's concerning for possible overcorrection, you've been treating them, it's only 11 o'clock in the morning and they've already gone up by 4 to 6. Then you can either replace free water, especially in the setting of heavy diuresis. And when you do that, you're trying to kind of match urine output, or you can use desmopressin to halt the diuresis. The third is what we want to try to avoid having to do, which is treatment of overcorrection when it already happens. So when you do that, you're using both desmopressin and replacing free water to try to get it back down. All right. Let's do another case. Anybody else want to read? Christopher.
68-year-old male nursing home resident was brought to the emergency department by EMS for altered mental status since early morning. He has been experiencing poor oral intake and has been noted to be withdrawn from social activities over the past few days. Review systems was negative, or nausea, vomiting, diarrhea, or fever. Physical exam showed stable vitals. However, the patient was cachectic, had dry membranes, was alert and awake, and was able to follow commands, but was confused. Significant laboratory data showed sodium of 167, chloride 125, potassium 4, creatinine 1.8, and his cell count was normal. CT at the head showed no infarct vascular.
All right. Okay, so what's going on with this patient, and what do we need to think about in terms of the workup, management, and monitoring? What's that? He's dry. Yep, he's dry. He's dry. He has hypernatremia, pretty high at 167, right? He's symptomatic. He's confused, right? All right. Cool. So next we'll talk about hypernatremia or too little water. So there are 3 mechanisms, but really there's one mechanism that we worry about. So there's free water loss, which is by far the most common and what we generally deal with. The other, water loss into cells and sodium overload, we generally don't see very often. We'll mention them just so you know what they are. So water loss into cells causes a transient hypernatremia, and it can happen with severe exercise or electroshock-induced seizures, and you get an acute rise in the sodium by as much as 10 to 15. And usually it just lasts for 10 to 15 minutes and then goes away. So we generally don't see this or worry about it. Sodium overload, also less common. The times we do see it is when it's iatrogenic due to hypertonic saline for treatment of something else, like in the neuro ICU. Or we don't really see, but in poisoning cases with children. In adults, it's very uncommon to have sodium overload just from intake. So unreplaced water losses is what we worry about, and really it can happen from the skin, the GI system, the urine, and then you can have alterations in the thirst or osmolar receptors. So a good rule of thumb is this doesn't really occur unless a patient doesn't have, quote, access to water. So either in elderly or dementia patients who are unable to kind of voice that they need water, or unable to get up and go get water, or obviously intubated patients in the ICU, which is what we often deal with. So generally, if the cause is very clear, like they come in with nausea and vomiting for 10 days, then workup is really minimal. But if the cause is unclear, then you can kind of go down this algorithm. You can check the urine osmolality. Generally, if they have intact hypothalamic function and renal function, then they should have concentrated urine. And so basically then you can stop, unless they're on medications that alter that. If it's low, then you can consider things like diabetes insipidus, and then you can give ADH to see if it's central or nephrogenic. And if it's in between, then it can really be DI, osmotic diuresis, or it could also be from water losses. One important thing, even if it's very dilute, it's good to monitor the urine and plasma osmolality while you're replacing water, because if the urine dilutes but they're still hypernatremic, then there may be a secondary thing going on. So correction, we generally use D5 fluids, either IV, or often we're replacing free water with tube feeds, or obviously if the patient can drink, you can replace with oral fluid as well. The question though is, how fast do we correct hypernatremia? What's that? 6 to 8. Anybody else? No takers? All right. So the guidelines aren't as clear as for hyponatremia, and there's maybe not as much data. But overall, we actually tend to be really conservative and too conservative in lowering the sodium in hyponatremia. The current practice and guidelines is no more than 10 to 12 millimole per liter per day. So really, it's a lot more aggressive than the correction for hyponatremia. And the idea is to try to avoid cerebral edema from rapid correction, but it's actually not very common to have that happen. And actually, there was a recent study done to look at correction rates and see if either a more rapid or more conservative approach had any difference. So you can see here, the way they defined rapid versus slow was either greater than 0.5 per liter per hour or less than. But when you looked at the raw data, the difference between the two, the average for the slow was about 10, and the average for the rapid was 14. So it's not like one was doing 8 and the other was doing 20. But when they looked at mortality, 30-day in hospital, as well as cases of cerebral edema, seizures, any neurologic complications, there was absolutely no difference. So, really, whether or not 12 should even be our limit is kind of up for debate. So when you're trying to correct hypernatremia, the steps to that: first, you pick your target sodium, so decreasing by 10 to 12 for the first day. Then you calculate the water deficit in order to get there. And then you add on kind of ongoing losses from urine and insensible losses. And then you replace the net, so 2 plus 3, in order to get to your target sodium. And then you just basically repeat that step every day until you get to your overall goal. Water deficit. this is the calculation for it. So basically your total body water times current sodium over target minus 1. So overall, you are usually going to use an online calculator, right? But we'll say our patient's 70 kilograms and 5'10". Using the online calculators, their total body water is about 25.6. So then you look at volume of water replacement. We'll do 25 times, they said 167, and our goal for the next day would be 155 to go down by 12. And so basically you'd end up with 1.9 liter deficit to get there. So then next is to look at the losses to include those. This is something we often forget about because we just think, oh, this is their deficit, we'll replace this and they'll be fine. And then we're shocked the next day when they didn't get to their target. But generally the insensible losses is estimated around 750 cc's. So at the very worst, you can add about a liter to your water deficit pretty much and be safe. Calculating the urine loss is a little more complicated. Here's the urine loss calculation. So urine volume times 1 minus the urine sodium and potassium over the serum sodium. And then this comes out for our patient to be about 500 cc's. So in order to do this, it's really important you have to know what their actual urine volume is. So you have to have good eyes and nose to know what that is. All right. And that is all I have for you. Any questions? I like chemo. Should I assign a new host? Says it's asked me to assign a new host
Already?
because I started as those. I'll make Dr. Lazar. I think I have to because I was the host.
No. We're gonna start a new meeting. With a new
Oh,
host.
you're just gonna. Oh, okay. Stop the meeting in general.
Shonda, you're gonna use this computer?
Yeah.